Welcome everyone to Firefly's CPD event tonight. Connor, I said tonight.
Hey, I better pick that out. Keep going.
Yeah.
Keep going.
Our CPD event tonight on the Richie Brace AFO. This is a product that we as podiatrists can use in our clinical practice to increase our scope of practice. Previously, most of us would have been taught at an undergraduate level to use custom-made foot orthoses or OTCs or strapping to effect mechanical change in the foot. And what this product does is allow us to treat some complex pathologies that previously we wouldn't be able to treat. So this is an excellent product designed by a podiatrist for the podiatric profession to treat complex pathologies of the foot and ankle. Tonight I've got my colleague Sarah in the house, and we're going to go through some questions and answer some of the common queries or dilemmas that you might have with regard to prescribing Richie braces.
Yeah, so we've decided that we've gathered our most frequently asked questions that we receive in the lab, and we're going to answer about materials, components of the Richie brace, and when to use a AFO as part of your treatment plan. In the second part, we will discuss different pathologies and give an overview on how we would treat them. So the first question that we get is, why use an AFO?
Okay, well an AFO, as the name suggests, ankle foot orthotic, essentially increases our ability to treat conditions of the ankle and the lower leg. So within that context, we can aid ambulation, so we can try and improve movement, or we can actually limit movement, so we can use it as a splint. In some pathologies such as drop foot, we can aid ground clearance and ambulation. So they would be kind of the key reasons to use an AFO.
Perfect. And what is a Richie brace? I know you've already answered it, but what makes it special?
Well, the Richie brace, which is very unique, is that the foot plate itself is a custom-made foot orthotic. And really, what does that mean? It means that it is a intrinsically balanced, custom-made foot orthotic that is very different than the traditional products that some professions use, such as arch supports. So what this is going to do is control the foot in 3 planes. So that will be the frontal plane, transverse plane, and the sagittal plane. What's unique about it is that the upright section at the lower part of this brace is actually custom made to the malleoli position, and therefore takes into account the ankle joint axis of the specific patient. The actual uprights on the top here are mass produced and added. Now, they can be custom made depending on the anatomy of the person, but in 15 years of prescribing these, I've only ever made one pair that has custom uprights. So really the bottom part is the custom made foot orthotic, but it has these additional components that are made to the ankle joint axis.
Yeah, and I mean, many say AFOs that we would see in our clinic that are wanting our help or us being involved, they would come in classically with a flat foot plate. So it's really that custom made part that makes the Richie brace so much better.
Yeah, so most AFOs are the back slab. So it's the back slab and then a flat foot plate. Yeah, absolutely.
And then you kind of touched on it, how you're dealing with all 3 planes, and I think we use the word joint coupling, so people are asking us, what is joint coupling?
Well, I mean, joint coupling was a term that I first came across when I visited Doug Ritchie in his practice in Seal Beach in California, and at that point we were exploring posterior tibial tendon dysfunction, and the new term that was evolving really was adult acquired flatfoot.
Yeah.
And what was coming to the fore was that if you actually severed the tibialis posterior tendon and did cadaver studies on it and you loaded the foot, it wouldn't actually collapse until you started to sever some of the main ligaments in the foot. So the deltoid ligament, the long and short plantar ligaments.
Yeah.
So really what developed then was that how are all these bony osseous structures connected? So how is that, forefoot connected to the hind foot? How is the hind foot connected to the ankle? and ultimately the lower leg. So joint coupling really is about that integrated connection of the different joints and how they work together. So when you start to see really advanced adult acquired flat foot or advanced lateral ankle instability, you're seeing this discoupling of joints, and really what's starting to happen is that the foot is disconnecting from the leg. So joint coupling is about getting all these joints to function, you know, as nature intended. So that's really the concept.
And I suppose then, when would you use a Richie brace instead of a custom-made foot orthotic?
I think that comes down to the diagnosis, and very much if there's any ankle involvement at all, then we're going to use a Richie brace.
Yeah, because the custom-made foot orthotic doesn't come high enough to really...
Yeah, and interestingly, for the benefit of the audience, you know, you may use the Richie brace for a period of time, so it's a rehabilitative tool.
Yeah.
And you may be saying to someone, you're going to use this for the next 8 weeks, 12 weeks, 6 months, or even 12 months. And then you're going to progress out of the Richie brace and into custom-made foot orthoses.
And I suppose that you touched on it earlier with the joint coupling. When you lose mechanical coupling within the foot and the leg, I suppose I looked into it to see what tests can we use to find out if we've lost that mechanical coupling, and it's actually Jack's test, or Hobsner, I can never say that maneuver. And you find that when you dorsiflex the first, if you're not seeing windlass mechanism activated or the tibia everting or externally rotating, what it means is that that mechanical coupling is lost, and you commonly see it in adult acquired flat foot deformity, and that's another telltale sign to use a Richie brace over a custom-made foot orthotic. And then, as you touched on some of it already, but what makes up a Richie brace? Like kind of the different components.
Yeah, well, in terms of the main thing that you're going to see is a 35mm heel cup. So it's a very, very deep heel cup. The deeper the heel cup, the slightly wider the product. So you have this wide foot plate, so you get more ground reaction through the foot plate onto the foot. The deep heel cup also adds a degree of contact and support control. And then you have these uprights that are made specifically to the axis of the joint. It usually comes with a sulcus length extension. You can have that to the Mets, or you can have it full length. The uprights, as I say, are mass produced, and then you have a thicker strap at the back for, you know, anchoring it, and two at the front, and these are riveted in place. Inside you've got soft padding, and bear in mind that all of these components can be changed. And that's something you need to explain to your patients, that in the same way that perhaps they get their shoes mended, you know, these items need to be replaced. And particularly when you're dealing with, you know, the severe pathologies, you will get wear on these at the lateral side or on the medial side, depending on the pathology and the diagnosis.
Perfect. And then what footwear does it suit? So are there specific footwear considerations? Are there limitations? I mean, when you're dealing with a product like this that has a 35mm heel cup, you're really looking at sort of athletic footwear. And I remember initially when I started prescribing them, the Brooks Beast was the recommended runner at the time. But many training style athletic footwear, it will fit. You do have to be quite robust in getting it into the shoe. So you'd normally remove the insert and then slip this in. This would be sitting back like so. These ones would be open, and then the person puts their foot into the trainer, make sure the laces are opened nice and wide, and then you would pop this up and make sure it's nice and tight here. There have been occasions for certain sports where we've modified the design to get it to fit into more slimline footwear, like soccer boots. Yeah, because we know, like the most famous one would be for the AFL. They have been shown to use the Richie brace, and I was wondering how you would get it into a football boot in that case.
Well, again, it comes back to the similar concepts around orthotic design. So what you do is you lower the heel cup. So what you can say is, okay, let's make this heel cup 20mm. Let's make it 25mm. Let's do a first-rate cutout to narrow it. But then you still have the benefit of this support back to the ankle joint. So it's again about the design, and we have fitted these into soccer boots, and certainly in one patient, you know, I've actually fitted a Richie brace into a Prada low cut shoe. So
Okay,
it can
so
be done.
it can be done.
It
It's
can be
just
done. Normally what I would
specific
do is I would
considerations.
start with this at
Okay.
the standard device, and if it works really well for the patient and now they want to get more active, or it's a sports star who needs it, well,
Yeah.
then you change the design.
Okay,
Yeah.
perfect. And that's all the frequently asked questions.
At this point, what we're going to talk about is 4 device types that are commonly used in our clinical practice. Well, in fact, 1, 2, and 3 are commonly used, number 4 less so.
Yeah.
So we'll talk about initially, Sarah, if you don't mind, let's talk about the standard Richie Brace, and particularly about the hinge.
Okay, so the standard Richie Brace has a fully articulated hinge, which means that you still have full range of movement in the sagittal plane. It's commonly used for earlier stages of adult acquired flatfoot where they still have full range of movement, so there's no kind of that bony subtalar joint issues. It's also used for lateral ankle instability as long as they have, again, a good range of movement.
Yeah, so our chat with Doug Ritchie recently, he said that this brace with the standard hinge is probably used in 70 to 75% of cases. So it is the go-to Ritchie brace, yeah.
Yeah, so that's your fully articulated hinge. And then the only thing that differs in the fixed hinge is that it has an extra screw to stop it from moving. So the whole idea is that this would be used if you wanted to restrict dorsiflexion at the ankle. It's actually fixed at 90 degrees to ensure ground clearance, but the main idea is that we restrict that sagittal plane movement.
So that's a good point you've brought up there about the ground clearance. So the fixed hinge, I mean, usually the fixed hinge is used when there's any form of degenerative joint disease, so arthritis, wear and tear of the hind foot or the ankle. So you splint it, you literally limit movement. But you mentioned ground clearance, so you can use this for mild drop foot. So it's fixed at 90 degrees, so it will improve the position of the foot in the swing phase of gait.
Yeah, exactly. So I mean, when it's to do with foot drop, what you're looking at is you want it fixed at 90 because they don't have the dorsiflexors and eversors to help clear it with clearance. And then when you're looking at the kind of the more degenerative joint disease, it's majority of the time, it's when either the patient is unsuitable for surgery or doesn't want surgery, then we'll look at something like this to limit movement as a conservative treatment.
Another thing that's important to note, when we say fixed hinge and limiting movement and so on, it doesn't limit movement fully.
Yeah, Doug was chatting about
Doug
that.
talks
That
about
was really
this.
good.
This is 5 millimeters polypropylene. This is not a big, thick, solid AFO back slab. So you still get a degree of movement. The key thing is that it can offload painful structures, be they soft tissue or bone. The other thing just to note is that when you have the standard hinge, you can convert that to a fixed hinge in our lab by adding another rivet and making it a fixed hinge. So quite often, even if there's a slight doubt, you start with a standard hinge, and then you progress to the fixed hinge, and you give the person the ability of, right, well, we can convert this. So why does that one have a different top cover?
Personal preference.
Couldn't resist asking that, Sarah. Okay, yeah, so that's just a personal top cover choice. Okay, so that's the 2 most commonly prescribed Ritchie braces. They're typically prescribed calcaneal vertical. And really what you're choosing is the hinge type, and that's really based on the pathology. And even on our order form, it tells you, here are the common pathologies, and here's the recommended hinge type.
Exactly. It's all about the ankle range of movement. So any queries around the ankle range of movement, that's when you have to think, do I need to go fixed? Otherwise, as you said, it's mainly the standard articulated hinge.
Yeah, I suppose I would maybe add that it's probably even more about the diagnosis. Because recently, you know, I had someone that had a significant syndesmosis injury, lateral ankle inversion, rupture of all the lateral ligaments. They also had a lesion on the talus. And what we wanted to do was to splint it. Now their ankle joint movement was quite good. But what we said was, no, we're going for fixed hinge.
Oh, because you wanted to fully offload.
Just because of the pathology.
Okay.
So that was the key thing. The third type that we use is a Ritchie brace dynamic assist. The dynamic assist is with a tamarack hinge, And this is a tamarack hinge, this little gadget that actively dorsiflexes the foot in the swing phase of gait. So this is used for flaccid foot drop.
Yeah.
And it can be very, very effective.
Yeah, it gives 15 degrees of dorsiflexion.
Perfect. And anything from 10 to 15 is very good. So you can imagine that if this is strapped tightly on the lower leg, it dorsiflexes your foot at the level of the ankle. So anyone suffering from a flaccid foot drop, whatever the etiology, be that spinal, stroke, brain hemorrhage,
CP,
etc., etc. Any type of flaccid foot drop, this is going to actively dorsiflex it.
Yep.
So that's a good product. Just note that these can fatigue,
Yeah.
and we've seen that in particularly active military personnel who have had some type of shrapnel injury to their common peroneal nerve, which has given them a foot drop, and then they start running on this product. So you may have to replace the tamarack hinge, and that's important to point out to the patient. The replacement of that is relatively expensive. These are what, 150, something like that.
and that's when people sometimes then choose the fixed,
Yeah.
so that is part of the consideration when you're trying to pick which one.
Yeah, but if the fixed hinge will not give you such an active dorsiflexion. No. So if you've got a flaccid drop foot, foot drop foot, I would go for the tamarack hinge.
Yeah.
The effect on the person's gait is instant.
Yeah, we have a case study actually that we will be posting at a later date that is an incredible story of how the dynamic assist changed a man's life. So that'll come up sooner. You've seen it before. But it's a good one.
It's one of those ones that immediately you stop the hitching of the hip, you stop the increased flexion of the knee, and they immediately walk normal. And it's like, whoa. So this is the last Richie Brace just to demo tonight, and this is the Gauntlet. This is not prescribed,
I've never prescribed
regularly because it's a relatively bulky device. But for some end-stage pathologies, you might find like a rheumatoid arthritic patient where the foot is completely collapsing. You've got subluxation of the talonavicular area, the base of the first medial cuneiform, and they're not suitable for surgery for medical reasons. This just literally laces everything together. You can get a 7-inch or a 9-inch, so it gives you this back slab. Again, the foot plate itself is intrinsically balanced, but in many cases it's neutral as it sits because the foot's arthritic, you can't change it. Whereas in these ones you can actually control the position of the foot with your casting. So we'll talk about that when we come to the pathologies in a moment. So I've used this a few times, and some other podiatrists have used it with good results, but very dependent on choice of patient. And it is quite awkward to put on and off. So sometimes if someone has advanced RA, it also affects their hands. But thankfully with a lot of the new biologics, we don't see the destruction in the joints as we used to see. But there's a place and a time for it, but not as much as these. And if you're going to prescribe something like this, please give us a call and talk to the technical support team.
Myself and Martin are going to give you a brief overview on how we would treat 4 common pathologies that we would see in clinic with a Richie Brace. I'm going to start out with lateral ankle instability. So the treatment goal of treating lateral ankle instability is to offload the lateral structures during the rehab process, and also to limit the... Sorry, one more time. I got so blank there.
No, keep going. You're just going to limit.
Would you be able
limit
to...
inversion moments of
Sorry,
force.
sorry.
So just start the sentence again. I'll cut it.
Please do. Okay, so the treatment goal of...
Okay, no, so stop and just give me a clean cut. So
Okay.
whenever you're ready.
The treatment goal of using a Richie Brace with lateral ankle instability is to control inversion movement and to offload the lateral structures during rehabilitation. I suppose the main decision as to which brace you would use for lateral ankle instability, you need to check the range of movement of the ankle. So I will do a non-weight bearing test, where I'm checking when the knee is flexed and extended, just to see is it gastroc tightness or is it true if there's a bony block or anything like that. And then I'll also do a functional assessment, so I'll get them to do a lunge test, and that's really just to assess how that ankle moves, the quality and range of movement. If I find that the actual range of movement is poor, I will then use the fixed hinge. And then if I find that the actual range of movement is good, I will use the standard articulated hinge, because it just controls that it's pure sagittal movement, and it just removes that inversion moment of force.
Okay, yeah, I think that one of the key things to talk about lateral ankle instability is the viewing of the lateral malleolus. So obviously you get your history from the patient coming in, and it may well be an early inversion ankle injury.
Yeah.
It's only happened once or twice.
Mm-hmm.
Or this could be something that's been happening for years. And again, as podiatrists, we're quite often trained to just focus on the foot
Mm-hmm.
and not so much on what's happening in the tibia and the fibula.
Yeah.
So if we raise our eyes ever so slightly, we can look at the prominence of either malleolus.
Mm-hmm.
And what's important with lateral ankle instability is that quite often the lateral malleolus becomes more prominent and posteriorly displaced,
Yeah.
whereas the medial malleolus disappears. And that's the beauty of this contoured shape, that it takes into account the specific anatomy of that patient. The challenge with those really advanced lateral unstable ankle joints is that they become arthritic.
Yeah, yeah.
That's where those joints are going, and at that point then the fixed hinge is much better than the standard.
Yeah, especially with, like, again, with the treatment plan, as I kind of said at the beginning, it's great to use it to offload the lateral structures while doing rehabilitation, and we'll have an example of rehabilitation that we would use with this device. But if it's at that chronic stage,
Correct.
how much
Yeah,
rehabilitation
the
is
reason
going
I
to have
brought
to
that
change.
up was the sliding scale, and it
Yeah.
depends on the severity of the condition.
Yeah.
So it can go from somebody who's going to use this for 8 weeks to 12 weeks, right through to somebody who's actually going to wear it forever,
Yeah.
based on the ankle pathology.
Or we have seen it also post-surgery, that
Yeah.
they go into this as part of the rehabilitation.
Let's talk about the prescriptions, Sarah. So let's say, you've got someone who's, that you described, it's an athletic inversion ankle injury. There's a rehabilitation program. The multidisciplinary team wants to get that person active and back into the
Yeah.
sport. So they're going to use a Richie Brace for maybe 12 weeks.
Okay. Yeah.
What would the prescription be?
So right away, I would just look at, what were the factors, intrinsic factors that may have caused the bad ankle inversion sprain. We would just see if they had that pes cavus foot, we may use a lateral skive just to create a pronation moment of force. Now, if the foot isn't involved, or if you feel that it was more of a traumatic inversion sprain, then I would just post it to calcaneal vertical.
Okay, so really, in most cases, it's always posted to calcaneal vertical,
Mhm.
but sometimes you might use
Different
a lateral
skives.
curvy skive.
Mhm.
So I think that's important for people to understand. You don't really need to get too concerned about, should I post the rear foot by X amount of degrees? Because in a Richie brace, when you post the rear foot by, let's say, 5 degrees,
The whole thing.
you have an
tilts.
impact on the lower leg. So really the advice is, with Richie braces, you're posting to calcaneal vertical
Mhm.
on probably 90% of cases.
Oh yeah, it's only.
And then really you're choosing a medial or a lateral curvy skive based on the foot
the
type,
foot type, yeah.
the pathology. Now, sometimes we will use a 4-foot extrinsic post
Mhm.
to sulcus, and that's used in 2 occasions. The first would be a varus post,
Mhm.
extrinsic to the sulcus, either 3 or 5 millimeters, or
Yeah.
and that's for a true 4-foot varus.
Yeah.
The only other time you would use the opposite of that would be a valgus 4-foot extrinsic to sulcus post, and that's for the very severe pes cavus. And again, that's usually 3 or 5 degrees, really dependent on the footwear. So standard footwear, go 3. If it's got a military boot or a welly boot,
Yeah,
or
you
a
can
hiking
go
boot,
more.
you can go more.
Yeah.
But apart from that, everything's to calcaneal vertical, lateral skive.
Yeah.
What about heel lifts?
I always put a heel lift on my braces. I just find that
Always?
for Yeah, always.
Yeah.
It's just, I just find for tolerance and things, the heel lift does help. I mean, we know that in some situations, a tight gastroc may compensate that midfoot, which can cause rubbing along the MLA. And I just find by adding a heel lift, it may reduce some of that rubbing.
Yeah, I agree. I quite often use a heel lift with them as well. And of course balance that on the other foot with an orthotic or an OTC with the same heel lift. Okay, so that really covers the lateral instability. And again, if you're dealing with any really severe cases, then phone into the technical support.
Yeah.
I mean, I've had a case where somebody was walking, and as they sort of had the heel lift, they supinated even further, and we couldn't deal with the irritation that was being caused right on the tip of the malleolus.
Mm-hmm.
And we used donut pads, we used thicker upright padding. Sometimes we can modify the brace by putting more poron on it. All that type of thing just didn't work. And we started to get an ulceration on the skin of the malleoli. So eventually what we did is we actually cut it off here.
Yeah, I remember.
So there was no lateral upright, but the person then used a large Velcro band to adhere the medial upright, and that just helped stabilize this part of the foot and the midfoot to the leg, and that was better than the alternative, which was no product at all. Okay, so the next pathology we're going to talk about is degenerative joint disease. So everybody knows that that's arthritis, and it affects any joint in the body. In this case, we're really talking about ankle arthritis or hindfoot arthritis. So you could be talking about subtalar joint arthritis, or maybe even mid-tarsal joint arthritis. So those are the types of conditions that, you know, people respond to steroid injections. Sometimes they do okay with footwear advice and orthotic therapy. And then they suddenly find themselves visiting an orthopedic surgeon who's talking about fusing joints. So in that case, that again is the standard Richie brace. And again, think this time you want to splint, so you put the double hinge in. In most cases, again, it's the calcaneal vertical, 3mm heel lift, fixed in that position, and the uprights take the load and offload the painful joints. And we've seen that being really successful for a lot of people.
It's a nice straightforward one, and I think at that stage the patient is very compliant, because they're going, this is one of my only options before, as you said, those extensive surgeries. So just, even if it works for a year or two, they see it as a success.
Yeah, I find that it's really successful for people that want to be active. So somebody who maybe wants to walk their dog, there's, you know, and even if people go like across fields or uneven surfaces, and they've got that type of arthritic hindfoot, that's a problematic, you know, that's not a nice position to be in. So this can just splint it, offload it, wear it even in a hiking boot, or a good runner, a good trainer, and it really works quite well. And
Doug kind of said the last day, he was saying that, look, even if you do cast them and they use it and it doesn't work and they have to get the surgery, it can always be used post-surgery to help getting them back on their feet. So it's not it can be part of the treatment plan from either side. Yeah. The other thing you can do with some of the significant degenerative joint diseases where they get subluxation of joints, you can put a sweet spot in. And the sweet spot would be a dell in the plastic matching, you know, the bony prominence. So that could be at the styloid process, it could be at the base of the first medial cuneiform, it could be at the tail navicular. And the sweet spot would create a dell in the plastic, and then that would be filled with poron. Other options, you know, in terms of design, you can add met pads, you can add poron arch pads, whatever you want that you would normally use in custom-made orthotic therapy can be applied to your Richie brace. So that really covers the sort of foot and ankle arthritic type conditions. So the next one then would be, why don't we go straight to adult acquired flatfoot? Yeah, adult acquired flatfoot is definitely an interesting one. I mean, it's been hard. I've been trying to look up the literature behind treating it and when to treat it, and across the board it says that stage 1 to 2 adult acquired flatfoot you treat with a custom-made foot orthotic or an AFO, but once it gets to 2B all the way through, the rest is surgery. And there's extensive research on surgery outcomes and all of that, but to stay strictly conservative, there's very little to back it up. Now there are a few studies which we will provide in the reference list that does show the success of using a standard articulated Richie Brace with a rehabilitation program, and then custom-made foot orthotics and footwear in order to get them back. So there is a little bit of conflicting when it gets around 2B3 stage, but we've definitely seen it in clinic that we've been able to use it and use it well to get them back and out of the brace. So it is an interesting one. I mean, the main reason behind using an AFO again is that it showed that it was the best at completely offloading the posterior tibialis tendon. It really just unloaded. It controlled the hind foot, so it reduced that valgus movement of the hind foot, and it also then it's taking care of those medial ligaments and preventing that MLA drop. So it really came from all angles and all the different aspects of adult acquired flat foot.
Yeah, you've just reminded me there that one of the really important things is that when you get a Richie Brace back for fitting is that you put it into the shoe and then you put the patient's foot into the shoe. Some people will send us photographs of a Richie Brace on a foot in the ground. Not in a shoe. So the shoe is really important.
Part of the treatment plan.
Correct.
Yeah.
So the shoe acts as a lateral buttress,
yeah.
particularly for the transverse plane problem that we see with adult acquired flat foot. The other thing that was a real learning curve for me was that you do get ligamentous repair over a period of time, and that people can come out of Richie braces and into custodial foot orthoses. Initially, I thought that if you had an adult acquired flat foot, that you were going to be using something like this infinitum, and I've learned that that's not the case.
There is once they get to a certain stage, you are just trying to manage what is there, but definitely the earlier stages. And it was also difficult because the term of success, a successful outcome, is different across all the evidence. So some people would see a successful outcome as they don't wear anything. They don't wear a custom-made foot orthotic or a brace. But from my point of view, I think a successful outcome is that they can return to activity pain-free. So that's also difficult when we all have kind of different goals. But yeah, it was found that a AFO that was intrinsically balanced with a standard articulated hinge was the best at offloading the posterior tibialis tendon out of all the other treatment options for conservative treatment. So the Richie Brace basically was described, but without the brand name.
Yeah, I think also in the early days when I started using these, I was using a standard Richie Brace sometimes for the more advanced pathologies, and sometimes it worked. So I was using it with the arthritic type end stage type conditions, and for whatever reason it offloaded and it gave the person relief. There's also the occasion when you attempt to use a Richie Brace and it's actually the horse is bolted, the person actually needs surgery. So once you enter into using these types of products, you're explaining to your patient that it's a conservative approach, and it may work or it may not, and it really depends on the pathology and how advanced it is and how to manage it.
It's how to manage the patient expectations, definitely. I suppose the only other part with adult acquired flat foot is that if you do want to rehabilitate it, there has to be a solid rehabilitation program. So we have an example of one that we'll provide for you as well, but Doug also kind of said it is about being strong as well from the top down, so it's a full strength conditioning program. It's not just around the foot. Yeah,
and of course when we see patients with adult acquired flat foot, it affects women more than men. Typically they're at least middle-aged. There is a sort of history of sometimes high blood pressure and also slightly overweight. The other thing that I find is a predisposing pes plano-valgus foot type. So that tends to be in the mix as well. So all of those things, more proximal strength around the hips, the core, the glutes, all of that's important. The other thing with the adult acquired flat foot is that's the one that you would certainly use to medial skive. The skives typically are in millimeters, so that's 2, 4 or 6 millimeters.
Yeah, and you're really lucky because there already is a deep heel cup, so you can go for that 6 millimeter Kirby skive because the device is already a certain width and deep heel cup. So, it gives you a chance to do that. So what's
your understanding of a Kirby skive? What does it actually do?
Well, from my understanding, I really hope I get it right.
Yeah.
From my understanding, a Kirby skive brings the element of correction closer to the joint axis, the subtalar joint axis. So it seems that you're pushing closer to that imaginary subtalar joint axis.
That's exactly what it does. So perfect. Well done, Sarah. Yeah, so 6 millimeters is quite significant, and that really creates a supination moment of force, or that's what we think it's doing. You know, the other thing with the adult acquired flat foot is definitely the heel lift.
Oh yeah, definitely.
Why in that case? Why do you think we would want to use a heel lift in that case? Anything in particular? Reference gastrosoleus?
Well, again, I think I've mentioned it earlier, but when the gastrosoleus complex is tight, we do see in a pes planovalgus foot type that the midfoot compensates a lot of the time, and so what we'll see is that as that gastro gets tighter, it bullies that foot, and that's the term I would use.
That's a great word. I love that. I love that. Sarah, remember she said that the gastrosoleus bullies the foot.
Not all feet, but especially that highly compliant
Well, especially
foot.
if you've got a lack of ligamentous integrity there.
Exactly,
and
yeah.
strength in the tib post tendon.
Yeah, and they did find that in all, now again I could be wrong, but in all of the acquired flatfoot cases that was in what I was reading, they all had that gastrosoleus tightness.
Yeah, and I would find that clinically, the more advanced and long-standing the adult acquired flat foot is, the gastrosoleus, rather than being a supinator of the midfoot, becomes a pronator of the midfoot.
Yeah.
So it's actually pushing the midfoot into the ground.
That does happen with what happens is when those other tendons fail, you will see the Achilles tendon.
Yeah, and I've seen
more.
some people, visit a medical practitioner with this sore foot, and they're wearing a court shoe with maybe 2 inch, 2.5 inch, and the doctor would say, look, well, get into something a little bit flatter. When in actual fact
That's
that
the
makes
worst
it worse.
thing,
Yeah, because now you've taken you've dropped it, more tension on the gastrosoleus.
Yeah, and that foot being bullied more. Yeah.
Correct. So normally I would say no, go get the heel higher.
Yeah, and that's
to
where
offload
footwear.
the midfoot.
Exactly, and that's where footwear again works really well with this. In this case, I mean, with all of them, we want that suitable footwear that's going to act as a buttress coming along the foot, because it's just going to give more control and it's going to offload the structures more.
Okay. Last condition we'll talk about is foot drop.
Yes, yeah.
The most common brace, I suppose, for foot drop is the dynamic assist tamarack hinge, and this is really for the flaccid foot drop. So you can correct that foot, put it in the correct position, you can bring the foot to 90 degrees at the ankle, and there is some pathology that is creating this flaccid foot drop, which affects the person in the swing phase.
Yeah, and they still have some active dorsiflexion or eversion. That's really key in this.
Yeah, and what sometimes happens is that if you watch the foot unloading, so they load the forefoot, and that's when you'll see this frontal plane collapse and abduction of the forefoot.
Yeah.
And that's when you need the custom-made Richie brace. I mean, we do have a version of an OTC Richie brace, which is a flat foot plate, but I just don't use it.
Don't use it.
For the difference in the cost to get the custom made.
Yeah.
Just doesn't make sense.
No.
And I've used it a few times and failed compared to when I've used the custom made foot plate. So pretty straightforward for your flaccid foot drop. Everything again to calcaneal vertical, just decide on the length of your top cover, tamarack hinge. The other brace that you can use for foot drop would be the fixed hinge, and this may be used sometimes with a little bit more of a spastic drop foot, and we could put, like, if you can't get the foot to 90 degrees but you get it to maybe 80 degrees,
nearly
you
there.
could put your heel lift on it,
Yeah.
which counters that, and
Yeah.
I've used that with some patients with good success, and really
I think the best advice you gave me, because I know when I was starting out using Richie braces, I wasn't sure whether to go with the fixed or the dynamic assist when it came to foot drop. So you kind of explained to me that I have to remember that the dynamic assist wasn't as rigid. So if they had, if there was huge foot rotation in other planes, that it was probably best to go with something more like the fixed. But then at the same time, if they couldn't get that heel to the ground, again going for something with the fixed, or if they couldn't get it down at all,
Yeah.
the Richie Brace wasn't
You
suitable.
just reminded me of, look at the sort of the width of this device, or these devices from behind.
Yeah.
The other thing to take into account is that the Tamarack hinge
Is
is quite
bulkier.
it's a wider product compared to the narrow fit on this.
Mhm.
So sometimes I gauge that on the patient as well,
Yeah.
and on their footwear. You know, this really flares out, and I think it's really suitable for the flaccid foot drop. If it's a mild foot drop, I tend to go for this
Okay.
because it's neat.
Yeah.
Or if it's something to do with spasticity, I go for this. And that's it. Keep it pretty simple.
Yeah, I've also seen you choose this one over the patient's activity levels, that you know, between yourself and the patient, you decided that they were going to wear through these so quickly that they'd have to get them changed nearly every few weeks because they were so active, so you decided to go for something more robust.
Yeah, and the thing to check is you can see that when this sits flat on the counter, and this is the dynamic assist Tamarack hinge, the uprights are placed in that forward position. Now, when this Tamarack hinge wears out, patient comes in for a review, you take the brace, you set it on the table. If you see the brace sitting like that,
Yeah,
the Tamarack's
it's worn
kaput,
out.
yeah,
Yeah.
it's gone. So that's your test. And if it springs forward like that, Tamarack's okay.
Yeah.
And of course we can replace them. So yeah, it's an increased learning curve for podiatrists to add Richie braces to their clinical practice. But oh my goodness, what does it do in terms of building your practice, especially with orthopedic referrals?
Yeah, it enhances your practice, and it enhances your scope, and you have other podiatrists actually referring to you, as well as orthopedic surgeons and physios. So.
Yeah, so I think that if anyone's interested in learning more about the Richie brace, don't hesitate to phone through and speak to the technical support team. You can come through and speak to myself or Sarah. I know most of you will want to speak to Sarah, but that's okay. So.
The last part then is that we will be going through a few case studies. I mean, over the years we've seen some amazing results, so we're just picking out a few case studies that we'll share with you as well.
We probably should show some of the failures too. You know, it's easy to pick the ones that work
Yeah.
all the time, because sometimes it doesn't work, and you have to be able to say to the patient, okay, we've tried this, we now need to refer you for further surgical opinion evaluation.
Yeah,
Yeah.
and I'm glad you said about failure, because sometimes, you know, the Richie brace just, as you said, the horse is bolted, it's just
Yes.
not enough, but when it is,
Well, we've got to a point, because we've been doing this for so long now, and I hope some of you will have the same experience, is that eventually we can educate our orthopedic colleagues to refer to us for Richie brace rehabilitation.
yeah.
And that's now part of a referral we get, and it's for chronic lateral ankle instability and adult acquired flatfoot.
Yeah, they were the two main
Yeah,
ones.
so okay, so thank you very much, Sarah.
Thank
Really
you.
enjoyed that,
Yeah.
and thank you all for your time and listening.